Thank you for tuning in to our webinar, First Breath 2018, using a new model to ensure tobacco cessation services reach families across Wisconsin. My name is Lauren Lauder, and I'm the Training and Technical Assistance Coordinator for the First Breath program with the Wisconsin Women's Health Foundation. Today, our objectives for this webinar are to discuss the need for tobacco cessation services among pregnant women, new moms, and their family members, describe the First Breath program and recent steps taken to improve our model, and identify next steps for you, our state partners, and what you can do to take to assist First Breath programming efforts. To accomplish these objectives, we will move through the following agenda. What is First Breath? Then, why First Breath? And finish with what you can do. So, let's start with the big picture question. What is First Breath? First Breath is a tobacco cessation program with the Wisconsin Women's Health Foundation, a 501c3 nonprofit in Madison. First Breath began as a smoking cessation program for pregnant women in Wisconsin, and since moving statewide in 2001, First Breath has helped over 18,000 women make changes to their tobacco use. Over the years, we've found that the additional support from First Breath programming has an impact. Among women completing the program, 83% reported making a positive change to their tobacco use, either quitting or significantly cutting down. So we've done some good work and we've made some changes. But before we go into the details of those changes, I want to share our journey with First Breath programming and why we've made those changes. As all programming efforts begin with a need, I'll begin with ours. First, let's take a look at maternal smoking over the years. Here's a graph of the self-reported prenatal smoking rates from 1999 to 2016. As you can see, the rate of tobacco use among pregnant women has been declining for the last 20 plus years. In 1999, 17% of all pregnant women were reporting tobacco use. And in 2016, we had our lowest rate in history at 11%. However, that 11% rate is not consistent across the state. So where are these women who are smoking during their pregnancy? If we dig into those numbers a little more, we see that smoking is both an urban and a rural health issue for our state. The first map shows county-specific rates of smoking during pregnancy. Counties that are darkest blue have rates over 20%, which means that in that county, at least 1 in every 5 babies are exposed to tobacco in utero. And some counties are closer to 1 in 3 births. As you can see, the concentration of these dark blue counties occur mostly in rural areas. If we switch from looking at smoking rates to the actual number of women smoking during pregnancy, we see a different picture of the burden of tobacco. In this map, the counties with the dark red color, largely urban areas, have over 300 women smoking during pregnancy each year. What ties this all together, both urban and rural, is poverty. Low-income families and women of color are impacted most heavily by tobacco use. Data supports this economic disparity as well. 1 in 5 Wisconsin women on Medicaid smoke during pregnancy, and among women with a high school diploma or less, this same ratio is true. Among other trends, 1 in 5 women who identify as biracial or multiracial use tobacco during their pregnancy, and 1 in 3 Native American women use tobacco during their pregnancy. What both the map as well as these rates should show you is that while we are making progress in our overall maternal tobacco use rates, there are still many women and families out there that need our help. So why did these numbers matter? Why are we concerned about maternal tobacco use? Because the health implications of perinatal smoking are tremendous. Smoking is the leading preventable cause of adverse birth outcomes. The leading preventable cause of adverse birth outcomes. Smoking during pregnancy is estimated to account for 20 to 30% of low birth weight babies, up to 14% of premature deliveries, and about 10% of all infant deaths. Women who smoke or who are exposed to tobacco smoke during pregnancy are more likely to miscarry, have a stillbirth, or go into early labor. Healthcare costs associated with adverse birth outcomes can be staggering. For example, a single very low birth weight infant born at 24 weeks gestation can easily cost a health plan over $500,000 for their first year of care. I mentioned it twice already, but it bears repeating once more. Smoking is the leading preventable cause of adverse birth outcomes. In addition to risks of tobacco exposure in utero, there are many health risks for children exposed to environmental tobacco smoke as well. The health risks for breathing in smoke are serious. The American Cancer Society says that secondhand smoke actually slows the growth of children's lungs and affects the brain and how it controls breathing. Because of that, a child around secondhand smoke is more likely to die of sudden infant death syndrome, have more severe and frequent life-threatening asthma attacks, get pneumonia, bronchitis, colds, wheezing, coughs, get more ear infections, and sleep poorly. Why do children have greater health risks when exposed to tobacco smoke? Unlike adults, infants and children are still developing. Their brains and immune systems are not matured yet, so chemicals from tobacco smoke do more damage to their bodies than it would to adults. They also have smaller lungs and breathe faster, which means they breathe in greater amounts of smoke. Children spend a lot of time exploring their surroundings. It's how they learn. Think of how often a small child is laid on the floor or crawls around on it. Their toys are on the floor, and many times they pick things up off the floor and put them in their mouth. This is easy access to third-hand smoke and its toxins that hide in carpets and rugs. What it really comes down to is that children are vulnerable. Their little bodies still are growing, and they are unable to defend themselves from tobacco smoke. They learn by exploring, and they also learn by example, which means that if a parent smokes, a child is likely to become a smoker too. For each year that a parent smokes, a child is at greater odds of becoming a heavy smoker in the future. We've learned over the past 18 years that if we want to help women make changes with tobacco use, we need to have a broader reach. Many of these women are surrounded by a culture of tobacco use. 1 in 2 pregnant women who live with another smoker will use tobacco during their pregnancy. Many of our participants grew up in households where smoking was common, and many of their friends were also smokers. Research also shows that it's incredibly difficult to quit when you're surrounded by other smokers. So, in summary, we know that tobacco use negatively impacts the health of pregnant women, their children, and families. We know that many women are still using tobacco during their pregnancy and postpartum. We know that if we do not address a woman's social environment, it is very difficult for her to succeed in making changes around tobacco use. So for all these reasons, we have made significant changes in First Breath programming in 2018. From its inception until this year, First Breath operated as a network of healthcare organizations and professionals, what we would call First Breath sites and providers, and they integrated a 5 A's brief intervention model into their existing prenatal care visits. Our First Breath providers were asked to complete at least 3 counseling sessions with data collection and incentive distribution with each participant they enrolled in First Breath. And from the Wisconsin Women's Health Foundation, these enrolled participants would also receive free text message support. But in the last 5 to 10 years, we've seen significant changes to the public health landscape. Many public health departments are serving fewer women and no longer having the staffing or budget to provide comprehensive tobacco cessation counseling for women. At the same time, we hear increasing requests from pediatricians, OBGYNs, and family practice clinicians for a referral option to help their patients quit smoking. And from women, we hear the need for smoking cessation specialists to help them through their quit process. We are fortunate to be involved in a large-scale research study starting in 2011 called Striving to Quit. Striving to Quit allowed us to implement expanded services beyond our model's basic brief intervention, which we knew from participants and providers was not enough. Following our 5 years with Striving to Quit, we put all of the data together we put all of our data together to further understand the key factors we needed to address in order to move the needle with tobacco cessation. On the left are the most significant factors based on quantitative analysis. On the right are the most significant factors that came out of our qualitative analysis. And those in the middle of the Venn diagram are those that were significant in both qualitative and quantitative. So these are the areas we want to focus on. Other smokers in the home, stress and stressors, keeping moms from maintaining their behavior change, and intensive services. Also, on a side note, if you'd like more information on Striving to Quit details and results, please write in your questions. We can definitely address those at the end during questions, or feel free to send us an email as well. Another valuable part of programming was participant advisory groups. These were groups of previous participants all over the state. The feedback we received from these women assisted us with so many aspects of our model transition. They provided feedback on curriculum, marketing, promotions, and messaging. These are just a few of the items participant advisory groups helped create. These resources are also available on our First Breath provider portal at www.providefirstbreath.org. These resources will be utilized in our new model of direct services. So with our new model in 2018, we've put together all the pieces. This new model moves away from the previous Train the Trainer model, where we went out to over 160 First Breath sites, across the state and trained clinics and providers on how to help women quit smoking. We are now receiving referrals from agencies statewide and have our tobacco treatment specialists provide counseling via home visits, phone, and text messages. Over the last 6 years, we have pieced together grants and contracts to offer the First Breath families comprehensive prenatal and postpartum services. The map on the left shows the patchwork of projects where we've tested and refined the referrals from clinics, home visiting protocols, text message support, and services for families. And as you can see, many counties have been left without services. So our goal with this new model was to move forward with offering services across the state, like the map in yellow on the right, where the same comprehensive services are offered in every county instead of the patchwork that's on the left. As I begin to share the details of our new model, let's start by addressing the question of who is eligible for First Breath. A First Breath referral can be offered to pregnant and postpartum women. That means a referral can be made during a prenatal visit, at delivery, or at a postpartum visit. In addition, other adult smokers can be referred to First Breath. So if a father or grandmother of a baby is a smoker and is present at an appointment, we strongly recommend that a provider would refer that person as well. That person does not have to be the provider's patient at all to make the referral, which is one of the things we love. We know that mom's chances of quitting significantly improve if those around her are also working towards the same positive changes. We also encourage providers to refer individuals across the behavior change spectrum, meaning those who have recently quit, those who are actively trying to quit, and those who are just thinking about quitting can work with a First Breath Quit coach. Our First Breath Quit coaches are trained to help with relapse prevention for those who have already quit and to increase motivation to quit for those who are thinking about it. Finally, referrals are not just for individuals who are using traditional cigarettes, but those who are using e-cigarettes, little cigars like Black and Milds, and other products like snus and dissolvables. Again, here's an image of our new streamlined process. A First Breath provider asks about tobacco use, provides a strong, personalized advisement to make a change, then completes a referral that comes to the Wisconsin Women's Health Foundation. First Breath Quit coaching is more intensive for pregnant women and new moms, or the new moms that have infants that are less than 6 months old. This intensive intervention includes one-on-one counseling from a certified tobacco treatment specialist or our First Breath Quit coach, home visits, phone calls, and text messages from pregnancy through 6 months postpartum, carbon monoxide breath tests, personalized quit plans, and gifts, gift cards, and educational materials. For other smokers, mothers and children over the age, and for smokers, mothers with children over the age of 6 months, and grandparents, partners, really anyone that cares for young children, the following services will be offered. Text message support focusing on smoke-free homes and reducing infant exposure to environmental tobacco smoke, full smoking assessment and education from a First Breath Quit coach, and if interested, a referral to the Wisconsin Tobacco Quit Line, where they can receive more counseling and quit smoking medications. So, what you, our partners across the state, can do. As our new model just recently launched, We need assistance in encouraging utilization of first breath services, and in doing so, also reaching high-risk groups mentioned earlier. This map shows a general breakdown of the number of sites, first breath sites, in each county. As you can see, we have several regions of the state with few to no first breath sites. We need your help with identifying and encouraging healthcare organizations in these gray counties to utilize first breath. So, to help identify potential sites, let's reflect on this criteria to be a first breath provider or first breath site. So if you provide health care or social services and work with pregnant women, new moms, or family members, then you can become a first breath provider. This is a simple process where you complete a 30-minute online first breath training and then offer referrals to those you serve. Identifying healthcare organizations to partner with can take just 3 easy steps. First, identify an organization within your service area. Share some information about First Breath. You could easily say First Breath is a free program that you can offer to individuals you work with. It's free tobacco cessation services. Also, the training to become a first breath provider takes just 30 minutes. It's online. And if you want more information about First Breath, that's available at www.providefirstbreath.org. Or if you or someone else has questions, you can always contact me, Lauren. Also, we are extremely fortunate to have received a grant from the Wisconsin Partnership Program to help us further our work, expand First Breath, work with families, and also to continue our work reducing tobacco-related disparities. Our goal is to continue to engage with women, families who may be at higher risk for prenatal tobacco use or infant and child environmental tobacco smoke exposure. We would love to partner on any initiatives aimed to reach and engage these groups. You can help us reach these at-risk groups by identifying healthcare organizations working with these groups already and encouraging them to offer First Breath. Also, please tell us about any community events that we can be present at, or contact me, Lauren, if you have any suggestions on specific resources for these groups. So before we end today's session, I want to review and recap all this information and identify our key takeaways. First, following nearly 2 decades of programming, studies, and evaluation, First Breath is now a streamlined Ask, Advise, Refer model. Within this new model, pregnant and postpartum women and their families are included in eligibility for First Breath services, and we're also available statewide. In addition, services for pregnant and postpartum women include working with direct services from a First Breath Quick Coach. Also, number 2, we need your help. We need your help as services have improved. We need assistance in ensuring any eligible person in Wisconsin knows they have access to it. Whether you become a First Breath provider or identify organizations that can offer First Breath, we could use your help. I would now like to open up the floor for any questions. Okay, one question that I see is, do you provide counseling anywhere in Wisconsin or in Madison and Milwaukee? And the answer to that is yes. We have First Breath Quick Coaches in 5 regions of the state. Each First Breath Quick Coach is assigned to their own region and serve all of the women referred from that area. And that would include the home visiting and phone calls and texting. Another question, do you have an info sheet we can share with community partners and or social media posts? Of course we do. In the handouts, I've included two of them. One is information on how to complete the training, and the other side of that is our first breath flowchart, so how implementation works. That can serve as one of the info sheets. Otherwise, if you have something more specific in mind, I'd be happy to talk with you about that. Another question, did diapers or diaper rebates come up from advisory groups as a nice incentive? That one specifically, I can't say for sure that came up. However, I think when it came to incentives, really moms were interested in things that were assisting them in their behavior change. So things that can keep their hands busy and really help them with skills in making the behavior change. There is another question about what the gifts and incentives are. I can share information of that, of course. So the referral gift is a mindfulness coloring book, and it's a smaller size so that you can easily put it in your purse or diaper bag, whatever it may be. But the mindfulness coloring books were actually used in our pilot for our new model and went over very well with our participants, seeing as we're trying to address stress and how to handle stressors. Using the coloring book was one of the positive incentives that women really liked. The other gifts are gift cards. So throughout their involvement with First Breath, our enrolled First Breath moms can receive Walmart gift cards. And those are also, just to go off of the diaper rebate, those gift cards are what we found more versatile and universal for those women. Another question, what sort of feedback have we received from our referral sites? Oh, what sort of feedback do we give to our referral sites? Each month we put out a First Breath monthly newsletter. In that newsletter, we share number of referrals we've received, as well as number of women who have consented to First Breath Quick Coach services. And then quarterly, we'll also share number of referrals for each site. So emails are sent out to each referred site on the number of women they referred. And then we can also provide a breakdown of which provider, so which staff person has been referring those individuals. And then of that number of referrals, we can also share, and we do share, the number of enrolled women or those who have consented to services with a First Breath Quick Coach. Another question, can anyone be a First Breath referral agency, or do they have to work with pregnant women? And that's a great question. We actually have very flexible guidelines on requirements for what a First Breath site is. Really, if you work with women or work with young families, that would, to me, be okay with offering First Breath services. Do we have any further questions? All right. One more. One last question. Is there any one-page handout we can take to meetings? And Charmaine, I might have to reach out to you more specifically on that and then maybe share with everyone else. But I did mention we have that one-page handout that's included in the handouts on this webinar, which has information on how to complete the first breath training. And then on the flip side, there's the first breath flowchart of implementation. But if there's other information that you think would be helpful to share with potential first breath sites, let's chat about that so that we can make a handout that might work better. All right, any further questions? If you need more information, want more information, please feel free to contact me, Lauren Lotter, at LLOTTER@WWHF.org. You can also call me. My number is 608-251-1675, and my extension is 122.